production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Cleveland Clinic, and the United Black Fund of Greater Cleveland, Incorporated.
Good afternoon and welcome to the City Club of Cleveland. My name is Jeff Pollack, president of the Woodruff Foundation and a longtime member of the City Club. It's my pleasure to introduce today's forum, a discussion of Ohio's behavioral health redesign with Barbara Sears, director of the Ohio Department of Medicaid, and Tracy Plauck, director of the Ohio Department of Mental Health and Addiction Services. The Ohio Behavioral Health Redesign, part of Governor Kasich's plan to modernize Ohio's Medicaid program, is being implemented to rebuild community behavioral health system capacity across the state through the integration of physical and behavioral health care services. Contracting with private managed care companies is scheduled to begin July 1, which by my reckoning is in 2 days. State Medicaid Director Barbara Sears oversees the Ohio Department of Medicaid, Ohio's first cabinet-level state Medicaid agency. Through its network of approximately 90,000 active providers, Ohio Medicaid makes care available to residents in all regions of Ohio. The department has become a cornerstone of the Governor's Office of Health Transformation, which Governor Kasich created in 2011. Prior to joining the governor's office, Director Sears represented the 47th District in the Ohio House of Representatives. She served as the majority floor leader, chair of the House Insurance Committee, and chair of the Joint Medicaid Oversight Committee. Tracy Plauck has been a member of the governor's cabinet since January 2011. She served twice as Ohio's state Medicaid director and also as a deputy director of both the Ohio Department of Developmental Disabilities and the Ohio Office of Budget and Management. Guiding today's conversation is IdeaStream reporter and producer Marlene Harris-Taylor. Marlene joined IdeaStream last year after serving as medical editor of the Toledo Blade. She was also a producer of NPR's Morning Edition in Washington, D.C. Marlene, I now turn the forum over to you.
Thank you so much. But I do have to make a correction. I've been with IdeaStream about 2 years now. So I've been in Cleveland 2 years. I'm so happy to welcome all of you here in the room today and to welcome those who are listening on the radio and possibly watching us on our YouTube stream. This is a very important conversation, and as the medical reporter, health reporter at IdeaStream, I've had the opportunity to cover mental health as a part of my beat, if you will. And so I've had a chance to become familiar with our mental health system here in Ohio and across the country. And so I know how important this conversation is. And mental illness is more common than people think. I know all of you in this room know this, but many people don't know that 1 in 5 Americans experience it in their lifetime. 1 in 25 Americans experience a serious mental illness in a given year. That's according to the Centers for Disease Control. It touches many of our lives, and yet as a society, we have struggled for decades trying to figure out the best way to help people with mental illness and with substance abuse issues. I'm so happy to be here with Director Sears and Director Plauck here to talk about the process that's already underway in Ohio to redesign the way mental health and addiction services are delivered. So let's start off, I know people in this room know this, but let's start off talking about why this is necessary. Why do we need to restructure the way we're delivering these services in Ohio? I'll start with you, Director Plauck.
Okay, well, good afternoon, everyone. Very pleased to be here today. This redesign is actually a multi-year component of Governor Kasich's overall healthcare strategy. Department of Medicaid for many years has paid for mental health and addiction services in the community using just about 17 local codes. And one of the pieces of rationale to redesigning the system was to actually align with federal coding standards, the same sorts of standards that are used by Medicare and private payers. So beginning this past January, our providers in the community have been using a standard set of codes that are much broader and much more granular than what they've used historically. This affords Medicaid to have more transparency into what the state is actually buying for those services. What sort of provider is rendering the service, the location of the service, and in some cases the complexity of the individual circumstance. So those are a few pieces, and Barbara, I don't know if you have anything you'd want to add.
Sure, and maybe even to bring it up into a little more holistic picture. So when Governor Kasich became the governor, one of the first things he did, as the introduction indicated, was develop an Office of Health Transformation with the idea that we need to look at healthcare in a much broader scope. And although we have all of our sister agencies that may narrowly look in specific areas, Tracy being the Director of Mental Health and Addiction Services, Aging, Developmental and Disability, Jobs and Family Services, Department of Medicaid, and a couple of other the agencies, there needed to be a convening and an organization sort of that looked at the broad umbrella of what was the final goal, what were we really intending to do. And so with the direction and the leadership of Director Greg Moody, they put together a plan that really looked at each of our different siloed programs and looked at the connectivity between those programs and how we could enhance the outcomes of what we were searching for. One of them was the behavioral health connection by bringing behavioral health into the managed care process. So this process, interestingly enough, began when I was a state representative, engaged in the Medicaid space from that lens or that viewpoint. And at that point we went, and you know this here in Cleveland, each different county sort of had its own thing going on, and we had 88 things going on throughout the entire state. Some incredibly productive and incredibly successful. Others could really benefit from some help and some kind of elevating up. And so that's exactly what we did. We elevated some of those dollars back up to the state so that we could then take benefit of those dollars by bringing in more federal dollars. That gave us a foundation of resources to be able to look at mental health and addiction services as an integrated part of our entire process. So that was sort of the step one, and that really happened around 2012. You know, we then looked at the opportunity with Medicaid expansion, and we said, we're ready for this. Ohio is prepared and ready to take on the challenge of expansion and everything that means because of the elevation, because of the system of convening all the sister agencies. So we had the opportunity to then take the expansion dollars, and certainly through Metro Health, expansion kind of demonstration that we did here, we knew we had a high likelihood of success available to us because we saw it being successful here in the Cleveland area. And so that was very important to us. It gave us faith that we could do this statewide. So that was around 2014. And then most recently, we did the redesign, which Tracy just talked on, that looked at a critically important part of the services we provide our 3 million Ohioans, but then also was narrowly focused on the behavioral health and addiction services area. And now the next step is to fully integrate it into our managed care program. For the first time in Ohio's history, we begin to look at a person as a whole person, from the very bottom of their feet to the very top of their head. Instead of saying, okay, we understand this part of you goes here, and from about the shoulders up, you're going to be treated differently, and there's going to be this disconnect or this barrier to real integration of care. And a lot of people assume that this was sort of a recent process because they see it now. But really, it's been going on for a long time, and it's been conceived and given birth to and organically brought up through the system, through not just our two agencies, but truly the entire state, which has been fun to watch.
Director Sears, can you talk about what was missing when, to your point that we're looking at just from the neck up, what was missing for people when they were trying to get care?
Sure. So as Tracy and I generally do, I'll start from a Medicaid perspective, and then she'll kind of jump in and provide some balance to my comments. So for us, we're missing a few things. So we spend the vast majority of our time in the Department of Medicaid thinking about how we can look at innovative payment models, how we can look at integration of care, how we can look at developing the analytics we need to know to understand how we need to fund the program, how we need to hold the program accountable. By having it all into managed care, I now know that I can connect my physical health providers with my mental health providers. I can look at that prescription drug component of it, and I can really take I can have one or two people sit down and really take an entire look at how can we help someone. Because we know it's all about that individual person, and we know that oftentimes someone who is struggling with mental health or addiction issues oftentimes is allowing their physical health to deteriorate. And conversely, people that are struggling with chronic illness and chronic issues oftentimes have issues in the behavioral health, mental health side, and clearly we know through the opioid issue and epidemic that treatment of some of those chronic conditions have created issues in the addiction side.
To give you an example of a person, and I've made many trips to Cleveland in my 7.5 years in this role, there might be an individual who is enrolled with a managed care plan, and the managed care plan pays for their inpatient hospitalization. And today, the Department of Medicaid pays for the community mental health and addiction services that they may receive. So a person might be a client of Frontline, and they may spend some time at Magnolia Clubhouse during the course of the week. They may experience some sort of crisis, and they decompensate, and they need a psychiatric hospitalization, and they may become admitted to St. Vincent's. But today, because they're two separate payer sources between the hospital and the community provider, there is no guarantee that the folks who are working with that individual in the community are even aware that the person's hospitalized. And I know in Cleveland, some of the community providers have gone the lengths of actually having people on their staff actually go to the hospitals on a daily basis to check and see if any of their clients are there. But that's not the most efficient way to do things, and it's certainly not helpful for discharge planning if you don't know that one of the people who has had a relationship with your agency for years is actually in an inpatient setting right now. So I think that's just kind of a tactical example of one of the things we're trying to overcome here. You have a single payer that is then working with the entire cadre of providers in support of a single individual.
Now you mentioned the expansion. Let's explain that a little bit, because there were people who came onto Medicaid when Ohio expanded Medicaid, and many of those people are receiving their mental health services and addiction services through Medicaid in Ohio.
Absolutely.
And so explain why Medicaid is so tied into this mental health redesign. Why aren't private insurers, for example, as tied in?
Thank you. That's such a great question, and it's such an interesting timing on the question, because we, as a legislator, part of what I required the administration to do was do an evaluation. And in the space of always be careful what you wish for, there are several things that as a legislator I push that I'm now being held accountable for, which for the most part is very good, but every once in a while my staff will remind me that this was my doing, or in part at least. But when the expansion rolled around, it became important for us to understand who was in that expansion population, what services were they using, what were we doing with that population, because really for the first time we were taking a program that was very specific in who it covered, and we were really bringing that out to a much larger population. And we found out that a good high percentage of those, the folks that we brought onto coverage through expansion, were dealing with mental health and addiction issues, a very large percentage of them. Very, very successful people that had something happen in their life that created a mental health issue, or they had a surgery or an injury or a chronic illness that led to an addiction issue that caused them to lose jobs and families and end up in through our program. And so we challenged ourselves to take an assessment of that. And just recently we have gone through our second assessment, and we're looking forward to in July, towards the end of July, having that report coming out where we can really start to measure the success of what we saw come in through the mental health and addiction services. But this becomes incredibly important because now we have, for the first time, a broad-based way to fund services, a broad-based way throughout the state to measure services, and with the redesign, now a broad-based way to identify who's using the services, as Director Plauk said, and who is providing the services. Do we have a mismatch in the provider base that we have? Do we need to encourage the workforce, different kinds of providers? Intuitively, we knew this. Now we know this. Intuitively, we knew what services were being used, but with such a small subset of codes, we didn't know. And so now we have the ability of actually knowing, which means that when we go to do our budgets and when Tracy looks at how she wants to allocate those resources out, we can do it with a confidence of knowledge instead of relying on assumptions and how we felt about something.
Since the Medicaid expansion occurred in January of 2014, we have had more than 630,000 Ohioans receive at least one mental health or addiction service as part of that expansion population. If you take nothing else away from this hour, please go out and support continuation of the Medicaid expansion. It has done so much for our communities, and I just encourage you to do that.
Yes, so the redesign has been underway for a while, and the goal of the redesign is to make things better at the end. But along the way, there's some pain, right?
Always is.
So what I'm hearing is that particularly this latest part of the coding has caused some problems for providers. Sure. So can you talk about that a bit, the problems providers are having and what kind of solutions you have for that?
Sure, there's a couple things, and I'll start, and then of course, Tracy, please, because you have such a deep detail provider relationship. So, you know, kind of in the broad brush, I mean, you can envision, we have not really done any significant change in this space. You know, truly we can identify back about probably 30 years. So 3 decades, we have fundamentally said, we're gonna set this aside and we're just not gonna make a lot of changes. Now that's a generalization, certainly changes have occurred within there. But as a generalization from our system standpoint, really there have not been fundamental changes. So we're creating this incredibly new change. We're asking providers to do things that providers have never historically done before, like identify who they are, like go through different kind of background checks, like get used to new code sets, which are complicated and challenging. We've also asked our managed care plans to take everything that they know about how to code and how to process on the physical side and create it on the behavioral health side in a way that is integrated and can be matched up so we can measure and identify and do analytical work on the data that we have the ability to access. So that's created a couple things. In fee-for-service, we did check runs that were based on our system. In managed care, you're now working with 5 managed care plans as opposed to 1 fee-for-service system. So as you can imagine, it's different. It's like driving your car and then going to a foreign country and jumping in a rental car. You have to figure out where things are at and what you have to do that's slightly different. It's doable, but it takes you a moment or two to kind of figure that process out.
So before, the providers basically billed Medicaid.
Right.
But now they have to work through other organizations
right.
as middlemen, if you will.
So some of their concerns are how timely will the payments occur. So we've put processes in place that will identify how quickly we need our plans to pay. Quite frankly, we took a model when we moved to the redesign where we did a contingency plan where if a provider felt uncomfortable with their ability to bill, that we would do a contingency plan that included a cash advance. So we could give them a cash advance so they had some help with their cash flow while they were making sure that they were being successful in their billing. We have stepped that up a notch and improved that as we move into the managed care process. So we've enhanced the way that contingency plan and the cash advance works to help to make sure. We certainly want to make sure that we have continued access. That's one of our missions. And we have seen through the redesign from when it started to now that we have seen an expansion of providers. We have seen hospitals where we had 8 hospitals providing outpatient services. We now have 24 hospitals providing services around the state. So we're seeing some benefit to the way the redesign was working, but still very cognizant of the concerns that providers have going into this next step. So for business folks out there, envision any kind of a reorganization in your shop. You do a strategic plan, you do a good old-fashioned SWOT analysis, you look at what those weaknesses, potentials are, you look at what those threats are, you shore up your strengths, you know, and you look at all your opportunities, and then you throw in that trend, and you look at sort of where you see trend happening at, and you bring that to bear, and then you set up some strategic plans. You set up a rapid response room, so you're giving technical assistance in virtually on-demand time. You do a contingency plan to provide for cash payment. You give the opportunity for providers to come into the office to sit down at the computer with our folks. We've gone out to providers. You do things, you keep certain processes in place so people have a comfort level to the inside process where they're working on the payment process to have a glide path. So you do all of those kind of things, and then you make yourself incredibly nimble for the one thing you didn't think about that's going to happen on July 2nd.
If I could clarify, Marlene, for folks in the audience, there were actually 2 phases of the work that we're doing this year. In January of this year, we adopted the new codes and the new reimbursement rates. And then July 1st, we're going to be moving the payment of those same codes and reimbursement rates into managed care. So there will be 5 payers working with providers, whereas in today's world, there is just Ohio Medicaid. We have 437 certified providers of mental health and addiction services in the communities throughout Ohio. Many of them have multiple sites, so there's actually, you know, more geographic access than 437. But just to put things in context, looking at the data through the end of March, which means that, you know, people had the growing pains, largely addressed. We had 26 providers of those 437 that were representing about 40% of the claims denials statewide. So we knew by the end of March, April, you know, there were still providers that were continuing to, you know, have struggling, you know, to get their IT vendors to work with the state's IT system. I checked that list of 26 yesterday to kind of discern, you know, what change has occurred since we reported in early May to the legislature on the progress. And the improvements are quite notable, and with a few exceptions, I mean, folks are doing notably better. I think people are acclimated to how to use the codes, and they're reporting anecdotally that the claim system's paying very consistently. And claims are turned around in about 8.5 days by Ohio Medicaid from the time that a clean claim is actually submitted for adjudication. So this is very consistent with how the Medicaid system was working before that change that occurred in January. Now, a concern that I hear, Marlene, is that providers are very anxious about the time frames that managed care plans will take to pay the claims once they assume responsibility in July. And the precautions that Barbara mentioned very briefly earlier are part of our state's response in concert with the managed care plans to help address those concerns. So there's a cash advance available to the providers from all 5 of the managed care plans if the provider seeks that option. There is an attestation or a commitment by the plans to pay it even more expeditiously than they normally would in the early months to help allay the concerns about cash flow that exist. And there's also going to be a post-implementation team that is staffed by state folks as well as representatives of all of the major statewide organizations that are interested in this topic on a weekly basis to throw up flags, talk about concerns that folks are hearing so that we can immediately work to remediate any concerns as they arise. So I think, you know, nothing is going to work 100% smoothly on July 2nd, I'm sure of that, but I think we've got an infrastructure in place that will allow us to be nimble as Barbara described, and we are very interested and ready to work with folks if they sense a concern.
Well, you know, when we talk about providers, we're talking about agencies that are on the ground providing these services for people in the community. So one of the concerns that I've heard is that some of these providers are really small, they're providing really specialized services, and having to upgrade their systems. Their computer systems alone could cost them thousands and thousands of dollars. So if you're an agency and you're working on a shoestring budget to begin with, and now you have to upgrade your computer system so that you can do all this coding. It's really putting in danger, is what I'm hearing, some of these smaller agencies. So is there any concern that we're going to lose some of these smaller agencies that are providing really specialized services?
This is something that we are watching very closely, and I think that this is not inconsistent with other types of healthcare providers. If you have a freestanding physician's office and they are considering, whether to purchase their own electronic medical record and try to continue the status quo with the IT costs that are associated with that, or if they're considering partnering with a larger organization. I mean, this is not a challenge that's unique to behavioral health. So with that said, those organizations that belong to statewide membership affiliations, such as the child caring agencies, there's an Ohio Association of Child Caring Agencies, they've done a lot of technical assistance to help get their members ready for this kind of evolution in the system, and how to, through provider networking, through bringing in national expert coders and such, really help to prepare. So I think there have been quite a few steps taken among the providers, and we're very thankful for that. We have talked with the Provider Association and the Adam Board Association about if they are concerned about a specific, small specialty provider that's having trouble getting claims submitted, or they're having trouble with how to use the codes to leverage what services they're actually rendering. We need to know about that so that we can provide technical assistance before it becomes an emergent situation. So we are available to do that, and we're making that known to folks.
And then if I could just add to that, one of the unintended benefits of moving to a national code set that really has the opportunity to impact those small providers, really all providers, but particularly those small providers, is many of our providers were Medicaid-only providers. Well, there's a big need for health care, mental health care, in commercial insurance programs also, and for folks that have benefits through an employer or an individual plan on the exchange. So by moving towards a national code set, this now allows a provider to think about the opportunity of expanding their practice into the commercial side of it, which would then give them the opportunity to develop a healthier payer mix. So instead of having all your revenue coming in from one payer, you now have the opportunity to have a commercial payer mix, a Medicare payer mix, a Medicaid payer mix, which ultimately can enhance cash flow and make a healthier provider. So it's a transition. I mean, we don't expect that overnight. But when you think about mental health parity, we know, and actually with the integration and the carve-in of behavioral health, we now, as a Department of Medicaid, satisfy CMS that we are fully in compliance with Mental Health Parity Act.
And CMS is the federal agency.
CMS is the federal agency that oversees Medicaid and Medicare. But it also, our commercial plans are challenged with mental health parity also. And yet there's an issue with providers. So this really has a way to shift care in the state of Ohio.
One of the, I think, elements that's really at the heart of the matter is workforce. And across behavioral health generally, from psychiatry all the way down to paraprofessionals, every discipline is struggling with recruitment and retention in many agencies, community agencies specifically. And so the Medicaid approach that was adopted in January, it pays higher reimbursement rates in many cases for individuals who have a higher level of credential. And this is to recognize their, expanded education and the scope of their authority in the clinical arena. However, we recognize that some agencies are struggling to find those independently licensed staff, or those more, and I see a lot of heads nodding in the room. I think this is a long-term, intermediate-term, and short-term challenge before the state of Ohio, as well as other states. And we've taken some steps to offer some workforce grants. We have done work with some recent federal dollars to help make investment in existing staff, clinical staff across the treatment agency, so that they can increase their level of training and credential so that they can bill those additional services or the higher rates, and in some cases offer additional services. So I did want to mention that because I think that's critically important to really all of behavioral health in this state.
Okay, one last question, and then I think we're going to transition into questions from our audience. So all of you out there, get your questions ready. So you mentioned that, how physicians' offices have had to go through this kind of a change. And what we've seen in that arena is that many physicians have decided, well, I'm just going to join a bigger organization to help me with these costs of upgrading. Do you think that this is going to lead to consolidation of a lot of these agencies to help handle this change?
Our department actually does the licensure and certification of agencies in behavioral health in the state. And over the last 7.5 years that I've been in this role, I have actually seen every year, agencies that sometimes close, but more often than not are merged or consolidated into larger agencies. And so this is something that has been underway, for a period of time, and I think that it will continue.
So it was going on anyway.
Yeah. So in some cases, I mean, this may be part of a catalyst for an organization to make that change, but if an organization is looking at this now, it was probably an organization that has been struggling for some period of time, and this is another component in their evaluation of next steps.
I see. Did you have any thoughts on that, Director
No,
Sears?
I certainly agree, and I think, quite frankly, you see that in all sectors of business, this consolidation of smaller, for better or for worse. I think that's a natural occurrence.
It's a trend that's happening. Okay, so I see Dan over there at the podium.
I am Dan Moulthrop, CEO of the City Club, and today we're enjoying a forum on the behavioral health redesign. May we have our first question, please?
Hi, Jean Polster from Neighborhood Family Practice, Federally Qualified Health Center. My question relates to the integration with medical care. In the redesign, what role do you hope that the healthcare sector and the primary care safety net will play in providing care to the individuals affected?
Yeah. I think with the new codes that were opened up in January, there is an opportunity for community mental health and addiction centers to actually bill some medical codes. For example, if they have a physician on staff, they can now bill physician codes at that location where they were prohibited from doing so in the past. So I think that's one way that we're assisting with integration. But Jean, to your question, I think that this hopefully will help to build more bridges between federally qualified health centers and other community medical practices with behavioral health. We've seen quite a few examples of embedding, one practice inside of the other in an attempt to be more comprehensive in terms of healthcare offerings to clients. We have expanded access to medication-assisted treatment in some communities by having exactly those types of partnerships. So a physician in a medical facility, oftentimes a federally qualified health center as an example, may be doing the prescribing related to the addiction treatment medication, and then the counseling and therapy related to that individual's treatment is actually rendered by a community behavioral health agency. Because that way, neither of the two have to build up the other sort of expertise when recruitment and retention is such a challenge.
I see we have our next question.
Thank you for coming. My question concerns the managed care organizations. They're for-profit companies. They want to make money. They have a lot of staff. Is that money coming out of the funding for behavioral health care?
So I'll start with that question. So when we look at the way we manage what we call our PMPM and the funding of our managed care plans, those dollars will actually move over to the managed care plans for funding. But then we look at those dollars on a regular basis to make sure that we're funding adequately, but we're not funding over also. So we work with our actuaries to develop that very specifically. And then we challenge our managed care plans amongst themselves to which ones are more efficient with those dollars, and then embed those efficiency conversations into it. It's an incredibly detailed process that may or may not be overly ripe for this audience without charts and graphs. But to your point, we certainly move those dollars into the managed care plans. And the benefit for us of working with the managed care plans is really a variety. Number one, with having 5 managed care plans that are statewide throughout the state, we have the opportunity for members who participate in our Medicaid program to have choice. Who do they want to be served by? And that becomes important because each of the different plans have their own their own culture and their own mission within sort of the global mission. So we have CareSource here in the room, and we know that CareSource could easily give you a list of things that they do differently and they do better than the other four, and each of them could go through that conversation. It also gives us the opportunity to step outside of the strict code set that the federal government through CMS requires that we cover, and allows us to bring what I call common sense into the equation. So they can provide some wraparound services through the plans that I, in a fee-for-service program, am not allowed to do. So I actually end up having a benefit of being able to have a more robust offering to a member than I can provide in a fully insured program, or excuse me, in a